Welcome to the Eye and Ear Foundation of Pittsburgh's Sight and Sound Bites. I am so excited to introduce today's topic, chronic rhinosinusitis, with my friend Dr. Eric Wang, who is the Executive Vice Chair and Professor of the Department of Otolaryngology at the University of Pittsburgh School of Medicine. The Eye and Ear Foundation supports the two world-class departments of otolaryngology and ophthalmology in their research and clinical endeavors. Every penny raised by the Eye and Ear Foundation goes to help research to cure the worst maladies. So this is a big topic, Dr. Wang. We have a lot of people on today. So a couple housekeeping tips. If you are a guest on today, you are muted. Use the question and answer function if you want to send any questions over so that I can ask Dr. Wang at the end of this. So let's get started.
Well, Heather, thank you so much. And thank you for all of you taking some time out on your Thursday. I know it's a busy holiday season, so a lot of people have a lot going on. So I appreciate you taking the time to come listen. And I'm going to try to tackle what seems like a common thing, but I hope to show you that there's a lot of variation within it. And there's some interesting things and aspects to it that I think we can kind of discuss and look into today. I've been very blessed to be the head of our rhinology division. Rhinology is kind of the study of the nose, and the sinuses are a big portion of that. And I really am very thankful for an incredible division that I get to work with. And I hope to show you some of the things that we cover and take care of, and also maybe some of the research advancements that we've been making in this area. So one of the problems with sinusitis is the truth is that term means a lot of different things to a lot of different people now. So these are Venn diagrams from our our childhood, youth days, and elementary school. And even though chronic rhinosinusitis can be the cause of sinusitis, there's a lot of things that people sort of think might be contributing to their sinuses. Dental infection is probably one of the most common, like it hurts in that area. Migraines are a relatively common thing because pain that kind of happens in this 4-quadrant distribution is often attributed to sinusitis. And sometimes it is, but many times it's actually a version of a headache. Sometimes even our ears, because they can manifest in this mid portion of the face, can also be the actual underlying cause, in addition to the things that actually happen in the nose. So the nose is, sometimes I tell people, a very simple thing. It doesn't have very many ways of communicating with us. And whether that's the ability to breathe because of structure, allergies and inflammation in the nose, or inflammation in the paranasal sinuses, they sometimes all overlap and mimic each other to some degree. And even in very rare situations, we can actually have tumors in the nose and the paranasal sinuses that mimic sinusitis. So there's a lot of overlap from a symptom standpoint, and it's certainly not any patient's challenge, but it becomes a diagnostic challenge for us to figure out. So even when we get down to this kind of these what we call the 4 cardinal symptoms of chronic rhinosinusitis, which are the ability to breathe out of your nose, the amount of drainage coming out of your nose, your sense of smell, and facial pressure. Unfortunately, these also have a fair amount of Venn diagram overlap, and they can either result in chronic rhinosinusitis, or they can actually just be allergic rhinitis within the nasal cavity itself. And the symptom overlap profile is pretty high. So this is why, it's really hard for our really bright colleagues in primary care medicine to differentiate that. And sometimes they just said, okay, you have sinusitis, or you have the sinuses. But what we really wanted to get to is being able to differentiate that. Now, part of the reason we're able to get away with it a little bit is that the first line therapy for both of these conditions is kind of the same stuff. It's nasal steroids. So that's like Flonase, and that's there to reduce inflammation in the nasal cavity. And sometimes it also then translates to the paranasal sinuses. And then saline. Saline, I kind of call it the teeth brushing of your toothbrushing of the nose. It's really kind of a cleansing agent. There's nothing particularly amazing about it. it actually has a history for a very, very long time. So it used to be believed that the Ganges River in India had these special properties when you wrenched your nose from it that got rid of sinus and nasal problems. And so over the years, we sort of realized that it's not any special water than Ganges, but it's actually probably the mechanical properties of getting stuff out of the nose, getting the things that irritate out, that really make people feel a lot better. And the truth is, the majority of people in both conditions, whether it's chronic rhinosinusitis or allergic rhinitis, get better with just these two straightforward nasal medications. So that's great. Now, I would be out of a job if that was the whole thing. So wait, let's get down to the what is the sinusitis aspect of this, And I think when we get past that first line therapy, we really have a challenge of trying to decipher, is the problem located within the nasal cavity, which I highlighted there in yellow, or is the problem primarily in the paranasal sinuses, which are outside of the nasal cavity and drain into the nasal cavity, or is it both? And so we really are trying to differentiate that when we get past first line therapy, because now we sort of have to consider what are the second or third line interventions that we're going to do. And it's really important for us to be able to distinguish that. But it's not as easy as we think it is because the symptoms are very similar. So by definition, chronic rhinosinusitis has to last for at least 12 weeks. And this has been validated by our American Academy of Otolaryngology, the American Rhinologic Society, the European Physician Statement on Sinusitis. So there's a lot of people who sort of give it this length because all of us get colds, all of us get nasal infections, whether it be COVID or otherwise. And typically speaking, those can last up to 4 to 6 weeks and still be considered acute. And then there's that in-between time called subacute, which we don't see very many patients on. And then for people who last longer, who get into this more lengthy range, then we start thinking about the term chronic rhinosinusitis. Now, it's those same 4 cardinal symptoms that I mentioned earlier. The drainage coming out of the nose, it can be from the front or sometimes isolated to the back. The feeling like the nose is blocked, a decrease in your sense of smell and facial pressure, but not classically headache. But symptoms, because they are overlapped with so many other potential disease processes, are not enough to make the diagnosis. And it requires some objective measure. So one can be a CAT scan, which is pictured below in the bottom corner, where instead of having air in the sinuses, we see material or fluid or inflammation. And the second way we can do it is by looking in the nose itself. And typically speaking, we use these fancy small cameras that can give us a very high resolution image within the nasal cavity itself. And this can be done in the office setting. So does that mean chronic rhinosinusitis is the diagnosis alone? Unfortunately not. Unfortunately, it's a term that actually can mean a lot of different things. And I think it's important for us to differentiate primary chronic rhinosinusitis versus secondary. So in medicine, when we use that terminology, what we're sort of thinking about is something that is primarily arises from the sinuses versus something that sometimes can be more global or sometimes can be adjacent, okay? So the secondary kinds of chronic rhinosinusitis can be local pathologies, and I'm going to look into that with you. The teeth can be one of those problems. We're going to talk about this concept called a fungal ball, which can be chronic, but at the same token, it has its own characteristic to it and is very different. And then there are these things that are more global, like they affect the whole body, and the nose is just one area for which symptoms can manifest. And that contrasts to primary chronic rhinosinusitis. So primary chronic rhinosinusitis is where the disease process is primarily within the paranasal sinuses and has some spread to the nasal cavity, okay? And those also come in sort of a diffuse versus a local, with most of them being bilateral and diffuse, okay? So we're going to dive into those subtypes a little bit, but I think this is a good introduction to say that that term, chronic rhinosinusitis, is not a catch-all diagnosis, but there's subtypes within it that are important for us to differentiate because the treatments are different. Okay, so let's start with the secondary ones first, because I think sometimes these can get confusing. So One of the most common we see nowadays is odontogenic sinusitis. So that means essentially something that arises from the tooth, usually the upper teeth in the upper jaw or the maxilla. And a lot of people, many people, those tooth roots go into that cheek sinus or maxillary sinus. And unfortunately, it doesn't tend to manifest with typical dental issues, because we usually get dental pain because when there's an infection, it erodes and pushes against the bone next to it. And that's what gives us the pain of the teeth, right? But in this particular case, what happens, which is highlighted there in the yellow circle, is that as that infection gets to push against the bone, it just ruptures into the sinus. And the sinus is a big space. So you don't get the typical dental pain issues that you often see in, like, if it happened in your lower jaw. And so this is a fairly common cause of sinusitis that can last a long time. Its most common symptom is really thick, kind of really bad smelling drainage. And that's because the teeth have these things called anaerobes, or bacteria that survive well without oxygen. And that's really common in the mouth, but very uncommon in the nose. And that gives this really thick, kind of gross stuff. Most frequently, it's only on one side, can sometimes happen in both, but classically it happens in one side. And sometimes people know about their dental problems. They've had a tooth removed on that side, or they've had other sort of dental interventions like root canals on that side. And then a lot of times, especially when it manifests as facial pressure, a little bit more than the other kinds of sinusitis. So you can feel a localized pressure in the area. You can see the purulence in the nose when you put a camera in the nose. There are other kinds of odontogenic sinusitis besides infection itself too. So one can be very common now, dental implants. So all of us see those commercials, and we have dental restoration. It's probably the best prosthetic we have in our world right now, is restoring people's teeth. And nowadays, these implants get placed with sinus lifts into the sinus. And sometimes, I would say the vast majority of time, that goes well. But once in a while, they can cause an infection into the sinus itself when a foreign body gets pushed up in there, which is the bottom corner picture with that this long spike. And then there are dental cysts and tumors that can grow into the sinuses themselves. And you can see here this endoscopic picture, which demonstrates actually the removal of that ectopic or not right placed tooth that we're removing from the cheek sinus itself. So in addition to the infectious aspects, we can get other primary things that arise from the teeth that affect the sinuses secondarily. So the treatment for this is almost always sinus surgery, and that's because in a way it acts like an abscess that's within it. Now sometimes you catch it really early and it's confined to the lower half of the cheek sinus. You can just treat it by having the dental issue taken care of. But most of the time when we see it, unfortunately, it's spread way beyond there. And it's gone in this very classic pattern where it starts in the cheek sinus and then it ascends to the ethmoid sinus and then finally the frontal sinus above. And that ascending pattern with the purulence is very classic for this particular pathology. Surgical drainage is very successful, but it does need to be followed with oral antibiotics thereafter. And then the most important thing is you have to take care of the tooth problem. So if there's still an infectious thing on the tooth, it won't make the symptoms of the bad drainage go away unless you deal with the primary problem. Okay, so let's talk about the second thing called a fungal ball. And you could look in this scan here and say, you know, Dr. Wang, this actually looks pretty similar to the other side. There's a lot of gray in one cheek sinus alone. How do you know this is not a dental infection? Well, that's a good point. And sometimes they can actually start from the teeth. But a fungal ball has these little characteristic calcifications on their CT scan. And that's generally speaking what differentiates it from odontogenic sinusitis, because some of the symptoms are pretty similar. Facial pressure, some drainage. But more often than not, this fungal ball actually can also have some difficulty breathing on that side. So what is a fungal ball? The truth is, we all have fungus in our nose. So if we try hard enough, every single one of us can get cultured fungus on our nose. And it's probably one of those one of those things that lives commiserate with us. It's not there to hurt us. But I tell people what sometimes happens in these fungal balls is you get the right collection and the right growth or the right group together, and it just starts to grow. So rather than living along with us, it starts to set up this architecture, and it doesn't invade the sinus. It's not a fungal infection. It's really just filling up the airspace of the sinuses. And once it gets to a certain point, now it starts to burst through the sinuses. It starts to erode the bone and push it out. And that's what actually kind of gives us our symptoms. So a lot of times people live with fungal balls for many, many years. It can happen predominantly in the cheek sinuses, but it can also happen back here in the sphenoid sinus. And so this is an axial CAT scan with that same sort of calcification and all the gray within the sinus. And this one presents a little bit differently because it's so far back in the face and the head. So here it usually presents with headaches as well as postnasal drainage. And the process is still the same. It still has this fungal debris that fills up that sinus and acts like a cork and blocks it off. And that's when all the bad things happen sort of behind it. So the treatment for this is sinus surgery. It doesn't require any antifungals. And here's a patient of mine who had probably the largest fungal ball that I've ever seen. So it's filling the whole nasal cavity. It arises from the cheek sinus. And all this stuff, if we were to put it under a microscope, actually is just fungal hyphae that you can see it's not invading. It's not trying to hurt the patient's sinus. It's just growing and growing and growing. And so the treatment is to remove all this fungal bulb. So we do this using these tiny telescopes through the nasal cavity. We can start to debulk and remove all this fungal bulb. And this one's a huge one. It blocks off the whole nasal cavity as well as the sinus. And this is the end result where we basically have removed it all from the cheek sinus. And this patient's doing great because the treatment for fungal ball is simply just removal. And once the removal is completed, you just have to heal from the surgery, which is a process that usually takes about a month or so. And you actually go back to your normal life. And that's pretty great. This one had blocked off more than one sinus because of its size. And that's what we're kind of showing looking up here into the frontal or forehead sinus above. But, these kinds of things are very rewarding to help people because you make a huge difference in their quality of life. So, behind those two localized kinds of secondary chronic rhinosinusitis, there's also these more global ones. The most common used to be this thing called cystic fibrosis, which is a genetic abnormality where within the lining themselves, the people are not able to push out chloride within the cell membrane, and this causes a lot of thickening of the secretions that normally are made. The second thing is primary ciliary dyskinesia. So what this means is that in the nose, we have these little hair cells called cilia on the top of our nasal lining. And what they do is they help push the mucus towards the back of the throat. And ideally, we make about 1 liter to 2 liters of mucus a day, which kind of always blows my mind. How much mucus that is. But the idea there is that this mucus catches all of the things that are in the air and it captures it within it so it doesn't get into our lungs. And then these little cilia push these mucus back to our throat and then we swallow it and it doesn't hurt us. In both of these processes, that process doesn't work. So in primary ciliary dyskinesia, the cilia just don't work. They're basically there, but they don't move anything. And so all that mucus just kind of gets stagnant, and you can see that in these two pictures here. In cystic fibrosis, what happens is the mucus gets too thick because the chloride channel doesn't work. And in that particular case, then, it's just the cilia are trying their hardest. They just can't move that thick stuff. It's just like they're fighting an uphill battle and they're not able to. And the end result is inflammation and what appears to be like infection in the nose. So, unfortunately, we still don't really have a cure for primary ciliary dyskinesia. And we're forced to do these very big non-anatomic surgeries for these people so that they can use other measures like saline rinses to be able to get out that thick mucus. They also have problems with pneumonias, and so it's a really challenging disease. Now, cystic fibrosis used to be the same, and you may or may not know, used to unfortunately limit people's lives to their teenage years. And then as we got better with treating the infections, people were able to live in their 20s and 30s. And then we had transplants for people's lungs and pancreas, and then people were living into their 40s and 50s. And now, actually through generous donations. So the Cystic Fibrosis Foundation, similar to our Eye and Ear Foundation, is very passionate about curing their disease process. And if it encourages any of you, it's through that private foundation that they were first able to come up with ivacaftor, which is basically a drug that helps this chloride process stay open, so that they're able to get more of it out into the periphery and thin that mucus out. And since that work came about through the donations of the Cystic Fibrosis Foundation, they found 2 other things that work on this particular protein at the cell surface. And nowadays, we're able to give this medication. It's called Trikafta by its brand name now, which contains all 3 of these versions. And we basically, to some degree, have controlled cystic fibrosis. In fact, I used to have to operate on 20 to 30 people a year for this condition. I think I do 1 operation a year now for it. So it's kind of an amazing advance that they've made, really changing the paradigm for these people. Trikafta can be taken as young as 2 years old. So in a way, this is something that as a rhinologist nowadays, it used to be one of the real challenges of our lives. And now we have this amazing new medication, which for like 75 to 80% of cystic fibrosis patients really makes a gigantic difference in their life. So one of those really amazing stories that's happened over these last few years. There's some other kinds of secondary rhinosinusitis that could be autoimmune, so our body is fighting itself, particularly the vessels within the small vessels within the nose. And then primary immunodeficiency. So when your body's not able to fight infections that you normally would be able to easily clear, in 6 to 14 days, those people can't clear them. And these are some pictures that sort of demonstrate that. All right. So those are some other causes of things that can affect the sinuses. How about the things that primarily arise from the sinuses themselves? So the most common we often talk about are polyps. It sounds like everyone has polyps or everyone knows someone who has polyps. But if you get right down to the real prevalence of it, it's really only about somewhere between 0.5% to 2% of the population in North America and the United States. So even though it's very common, you heard, oh, the doctor told me I have polyps. The truth is it's not actually so common. And polyps, really, I'm going to explain to you a little bit more, are the end result of chronic inflammation. So it manifests primarily as nasal congestion because it blocks the nose. And as it blocks off the nose and the sinuses, and that inflammation is occurring, you make more and more drainage. And at some point, it can block off the nose enough that our sense of smell, which is contained at the roof of our nose, can no longer get the little odors to the top of our nose, and that blocks our sense of smell. And recurrence of polyps is really common, and it's driven by this thing called type 2 inflammation. Okay, so type 2 inflammation uses IL stands for interleukins, but basically what it describes is this pattern of inflammation that we see. And the other two most common disease processes where you see type 2 inflammation are asthma and atopic dermatitis. So some people have hypothesized that it's sort of a spectrum of diseases, but in truth, all of them are mediated by the same sort of inflammatory process. So what does that mean? So I think that it's important to sort of think about the balance that sort of has to happen in your nose. And I use the idea of a scale or a seesaw to help explain that. So in an ideal world, our nose actually needs inflammation because that's the way we clean our nose. So that's the way we produce that mucus that captures all the bad things in the air and then pushes it to our stomach and gets rid of it, okay? So we need a process where, at least at sometimes, our nose gets inflamed and those cytokines go up, or those signaling molecules go up, and that inflammation occurs. And then we clear all those other things. It helps us fight infections and all the rest. And then we have regulatory cytokines that then rise, and our inflammatory cytokines go down. And what that does for us now is now we can breathe better. Like we can breathe and we can smell. And so it's always this kind of up and down balance between the two. A scale is one way of thinking about it, but a seesaw is another. Like one goes up and the other goes down. And that's the way we're supposed to live. But unfortunately, in chronic rhinosinusitis, that gets broken. Okay. And typically that happens in 2 peaks. There's a peak that's fairly early, like in the early 20s. And that's actually the smaller peak. The more common peak is that sometimes happens in your mid 40s to your mid 50s. And unfortunately, we don't really understand what breaks the scale. But those inflammatory cytokines go way up, and the regulatory cytokines go down. And so this inflammatory process now begins to be dysregulated, and that imbalance makes us feel like we have an infection because we fight infections by inflammation. Okay, but it's really not a primary infectious process. So this idea that chronic rhinosinusitis equals a chronic smoldering infection is really not the case. It's really that inflammation, which we associate as infection, because that's what we get when we have a cold. But really what it is a dysregulation of that balance system that's supposed to happen there. And once the balance is thrown off, we get this chronic inflammation. And in one of its most end stages, the lining gets so swollen that you actually get these pockets that actually pooch out, and that becomes these polyps. So, one of the biggest things that we've advanced from the 80s and even maybe the mid 90s or so is this idea that chronic rhinosinusitis is not a smoldering infection that doesn't go away. It's really an inflammatory imbalance that is really, really much more akin to asthma than a chronic infectious problem. Okay. So this has been a huge paradigm shift in our field. And I think you'll see as we talk about treatments that that's really been reflected. Okay. So establishing the diagnosis. So in a very gross way, for primary rhinosinusitis, we tend to kind of clump them into those that have sinus inflammation without polyps and those that have polyps. Okay, so for the group without polyps, they have all the cardinal symptoms, but they tend not to have as much difficulty breathing out of their nose. They may tell you they feel some pressure or congestion there, but they can still breathe through their nose. Okay, but a lot of times they have a lot more facial pressure than the polyp group. So that's why a CT scan is actually really critical in this population. So this is the same patient, okay? So the endoscopy actually looks pretty normal because we don't see anything. And when you haven't had an operation, the endoscopy really shows us the exit points of the sinuses, more so than within the sinuses themselves, because these sinuses have really, really tiny openings into bigger spaces, or they have a lot of different rooms, and you can't see into each and every room. And so the endoscopy, when you haven't had a surgery yet, has some limitations because of just looking at what exits from the sinuses. So that's where a CT scan helps us a ton. So a CAT scan, of course, can look into the depths. And it can tell us how this patient, whose nose looks really normal on endoscopy, actually has a lot of sinus inflammation. And this is the kind of patient that you can really help. All right, let's contrast that with polyps now. So if you take away the no polyp group and you go look at the big polyp group, these people, they actually rarely have facial pressure, but they have a lot of difficulty breathing out of their nose. In fact, that's probably the thing that bugs them the most. But they also lose their sense of smell quite quickly, and the thick drainage can be terrible. Okay, sometimes it can be as thick as like raw honey or almost like peanut butter stuff, which can be really, really difficult. And most of the time, this goes on for a long time, and it's not so common to have any facial pressure in this group. So, and this group you can usually see on endoscopy. So that bottom picture actually shows what polyps look like. It's kind of this, like these little outpoochings. I kind of used to think they look like peeled grapes, where, grapes have a lot of fluid in it and very little tissue. And that's kind of what these are too. It's very little actual tissue, but it's a lot of like this inflammatory fluid that has sort of filled that lining and caused it now to pooch out. The CAT scans usually look terrible, where it's all gray everywhere. And both measures kind of are complementary. But this is where endoscopy is really a little bit more valuable, whether you've had surgery or not had surgery in this particular setting. So this is what it looks like in motion now. So this is a septal deviation, okay? And then here, the sort of the polyps above it, this is the right nostril. And you can kind of see this watery stuff. It fills up the whole nasal cavity, and it blocks off this patient's breathing, and the same thing on the other side. And the two processes kind of add together to make it more and more difficult for that patient. So there are subtypes of chronic rhinosinusitis with polyps as well. So this is a subtype that we have traditionally called allergic fungal rhinosinusitis. And just like that fungal ball story, actually our body is not being invaded by fungus. It's not a fungal infection. But what it is a response of our body to the fungal elements in the nose. And it causes this really, really robust inflammatory response. And the way you can tell is in the operating room, it's this kind of, I think it looks like raw honey. Some people describe it as peanut butter, but this stuff is thick, tenacious, um, really inflammatory stuff that characterizes this particular subtype of rhinosinusitis. We can usually tell on the CAT scan ahead of time because we call it differential densities. But basically what that means is there's two colors of gray on the CAT scan. There's a lighter gray, which corresponds to this eosinophilic mucin, and there's a darker gray, which corresponds to the nasal lining being swollen, okay? And this actually is not so common in Pittsburgh, but in Southeast United States through Texas, it's actually very common. It's probably the most common kind of nasal polyps in the South and Southeast. It's also common in other parts of the world, like the Middle East and Southeast Asia. It's less common in Pittsburgh. But sometimes we still see this eosinophilic mucin actually contribute. B.J. Ferguson, who is one of the real pioneers of rhinosinusitis here in the Pittsburgh area, wrote her trialogic thesis on eosinophilic mucin. So they don't have the fungal components, but it still has this thick stuff. The disease process is not as bad. But the treatment for both of these, at least traditionally, has been you had to open up the sinuses and get this stuff out. Because if you didn't get this stuff out, the recurrences were really, really high. And you needed to be really thorough in getting all of this stuff out. The last subtype of chronic rhinosinusitis with polyps I'm going to mention is aspirin-exacerbated respiratory disease. So this used to be called Samter's triad, okay? And this happens a little earlier than traditional chronic rhinosinusitis. It usually happens to people in their 30s, maybe their 40s, okay? And it starts with nasal drainage, and then usually they get asthma, and then finally they get this inability to take any ibuprofen or aspirin. Very few people take aspirin nowadays, is the truth, but typically ibuprofen. One of the other really weird things about this is you can almost predict these people because if you ask them, when you drink red wine, not everyone drinks red wine, but if they happen to drink red wine, if you drink red wine, you get a whole lot of nasal drainage. And they'll say, oh yeah, doc, for sure. I first noticed that, and it's like all this stuff comes pouring out every time I have a glass of red wine. And it's something about the tannins that really make it very specific for this group. So we don't entirely understand how this disease process works yet, but it's basically an acquired metabolic condition. So obviously you didn't have it at birth, it happens later in life. And what happens is aspirin upregulates this COX-1, COX-2, and that causes all of these negative inflammatory effects like your lungs and your bronchus getting tight, and you get all of these inflammatory profiles, which then also manifest in the nose as well. So nowadays, we actually have a very relatively straightforward way of diagnosing this by capturing 24 hours of urine for a measure in that cycle. So my latest partner, Garrett Chobe, comes from the Mayo Clinic that pioneered this test. And it's really very, very specific for this particular disease process, but it's only kept at Mayo Clinic, so we usually have to send this out when we do this. But it is a way that we can look at the specific diagnosis. And the reason we want to differentiate is that there are different medical treatments that are specific for this disease process. So montelukast is singular. So some of you in the audience may have taken this, like it used to get prescribed for every kind of sinusitis, but it really only works in this particular subgroup because it sort of blocks this end pathway. And there are infusions like xyluten that can be used as well to help with this. So this is very specific for this particular disease process, and that's why you want to be able to establish that diagnosis. The other thing you can do, which sounds a little bit crazy, is that you can actually do a sinus surgery to kind of take out the bulk of their polyps. And then you can actually give patients aspirin. You give them increasing dose of that same thing that exacerbates all of their problems. And it's almost like, it's not quite allergy shots, but it's the idea that we get them used to that aspirin. But it's not so easy to do because for the foreseeable future, you have to take 2 tablets of aspirin a day. So that's 650 milligrams of aspirin. But it does improve, it tends to improve people's symptoms. this is really not viable if it's a woman in their or a person in their 30s who wants to have a child, because you can't have NSAIDs during that time of pregnancy. So this is a challenging thing to do, but it does improve both symptoms and polyp grades. So it's another very unique kind of thing that is done for this particular disease process. We do have the ability to do this here at the University of Pittsburgh with our allergy immunology colleagues. Okay, so we've talked about a lot of subtypes. Let's talk about our treatments. And the primary goal here is we have to reduce that inflammatory burden, okay? So when you have polyps, these are the things that have level 1 or grade A recommendations. So you can use saline, that again cleanses the nose. You use topical steroids. So the idea there is you give the steroids to the nasal cavity so it doesn't get all into your bloodstream, okay? And then you can do that either with on-label sprays, which are okay, or you can use an irrigation and you can carry a medium strength steroid to the nasal cavity using this sinus rinse. And that probably has a little bit better effect. And then you can give oral steroids as well in this particular disease process. But there's actually a recommendation against antibiotics themselves, except if you have a secondary infection, because they really aren't that efficacious in them. Now, without polyps, that changes. So you still have saline and you still have topical steroid sprays, but antibiotics have a small but consistent effect in this group, okay? And even though Z-Pak or azithromycin actually has very poor sinus penetration, you can use it in this particular case for its global anti-inflammatory effect. And that's been described particularly in Asian populations, like in Japan and Korea, they've used that therapy. But interestingly, oral steroids, which are one of the things that polyps really help with, and huge, big time global anti-inflammatories, are not recommended in this disease process, as are budesonide or medium strength steroid irrigations. And this is by our American Rhinologic Society paper called the ICAR statement, so the International Consensus Statement on Allergy and Rhinology. Okay, so why do they have such great recommendations? Well, for nasal saline, it's because there's a lot of randomized controls for it. And when you use quality of life measures and people's reporting measures, and even when physicians look, there's a big difference when you use saline rinses. And it takes a little bit to get used to kind of figure out how to use it. But once you do, there's some very significant benefits to it. Now, this is the tables from the ICAR statement, and I don't mean for you to read them all. But basically, if you group all of these different kinds of nasal steroids together, it has a level 1 evidence because there are randomized controlled trials that demonstrate the benefits of these particular medications. Now, if you use off-label budesonide, which is usually used for asthma, it comes in this little vial of steroid that you can add directly to the sinus rinse and then use this as the carrier to the paranasal sinuses. There's only really one randomized trial, but it has a lot of indirect evidence, and most rhinologists, including myself and my team, use this with a lot of regularity to control particularly polyps. Well, what about topical antibiotics? You get this picture here with all this gross stuff coming out of someone's sinuses. Unfortunately, even though this can be relatively routinely used in some people's hands, there's really not a lot of evidence supporting it because it fails to demonstrate consistent benefit when it's been done in trial. And again, there's some case series where they didn't really compare against anything. They just said, hey, do you feel better? There's some efficacy there, but it's really, its role may be in very specific, unusual circumstances. But there are some, and the one we use most frequently is this drug called mupirocin, which actually our body can't, you could swallow a whole tube of this, your body can't absorb any of it. So it's really quite limited to its topical utilization. That can eradicate staph. So that's probably one of the few interventions where there is a fair amount of evidence supporting that. So what do you not use? So antifungals are something you just don't use. And that's because there really have been a lot of trials. This was popularized also by the Mayo Clinic back in the 90s, this idea that amphotericin would make a huge difference in people's, amphotericin is an antifungal. When you put that in a rinse, that it would make a huge difference in people's sinus inflammation. Amphotericin is actually fairly anti-inflammatory, But all the evidence to date has suggested there's really no potential benefit. And there's of course a cost, and then there's a harm. Even more so, this has proven to be the case for systemic, or if you give antifungals via tablet or injection into people. And it's because you can really find fungus in everybody. Okay, so really, there's not been enough evidence to support this. There are still some people who do it, but the evidence has sort of moved towards not using this at all. And I will say in my career, I've never used an oral antifungal for this particular issue. Okay, so those are some of our topical or nose-driven treatments for this. How about surgery? So the analogy I make for people when I do surgery for their nose is that I'm not going to cure them. Okay, so this is me doing a surgery. And what I'm really trying to do is actually take all of these little rooms, okay, and then create one big common space. So I tell them it's a little bit like HGTV. Okay, so HGTV takes these rooms and then they knock out all this drywall, this non-structural walls, and they create this big open floor plan. And that big open floor plan looks great, right? It looks awesome. And then they sell it for a lot of money. Well, unfortunately, we don't sell it for a lot of money. But what we're trying to do is we're taking all of these small rooms, your cheek sinus, your maxillary sinus, your ethmoid sinuses between your eye, your sphenoid sinuses in the back, your frontal sinus, and you create one common cavity per side. And that allows us to now distribute drugs in a much, much, much more efficient way when we deliver them through the nasal cavity, because they don't have to get to all these various little spaces. They get to one big common cavity, and that which is depicted there. And so instead of trying to get medications to all these little spaces, we're really getting it to one big open floor plan. And so surgery is not a curative thing, like you get your appendix out and you're done. Surgery is an adjunct to the delivery of topical medications. So we're trying to deliver these anti-inflammatories because, again, if that inflammatory balance exists and it's still there, those steroids can help bring it down, but only if it gets to the places that count. And so by using surgery as an adjunct to these topical medications, we could control the majority of people's symptoms. Okay, so that's the idea there. And so there are adjuncts we can use in the operating room to deliver those steroids. This is called a propel stent. So this is a proprietary thing where that stent, which is depicted here, can then, as it gets degraded, it elutes steroid into the sinuses. Cheaper, you could actually just use a sponge like this, which is made out of chitin, and then infuse it with some steroid. And that can kind of distribute it after surgery to that big open cavity. And so when you combine this idea of topical therapy with surgery, you really get a multimodality treatment for the control, not the cure, but the control of chronic rhinosinusitis. And so this is really one of the oldest practices in the United States. This is Ralph Metzen, a good mentor of mine at the Mass Eye and Ear. And basically, he took his cohort for 5 years and really compared how they did. A SNOT-22 is one measure of how people feel they have control of their sinuses, and this is what we use in our clinics as well. And you can see here, this is how they feel before, and a high number is bad. And then when they have sinus surgery and give topical medications, you see that there is a significant decrease in improvement in people's quality of life. That can be sustained up to 5 years. So it doesn't matter what you give afterwards. Well, this is a really unique study. This comes from Richard Harvey, who is a friend of mine in Australia. And Richard did this really, I don't know if we could actually get this done in the United States, to be honest with you. But what he did is he took surgical patients and he blinded them to either a spray or steroid irrigations for a whole year. So you got a spray that sometimes was active with steroid in it, or you got a spray that was just saline and it was blinded to you. Or you got irrigations for which there was active medication, or the irrigations were just saline. And although both groups improved, what it really showed was that the irrigation was actually able to improve symptoms like overall nasal blockage and drainage. So those two big symptoms, he was able to show a pretty big difference for the benefit of steroid irrigations. And that's why a lot of us use that over time. The question always is it safe? And so this is a very small study, and there are lots of these smaller studies where we sort of measure the role of steroid irrigations by measuring people's blood. and seeing if it affects their overall, what they call HPA axis. That's a hypothalamus pituitary adrenal axis. So that's basically what steroids affect, and it's a way to measure it. And in this study, which is similar to many that came out of Chicago, there was one person who had a real big drop. Well, when they dived into it, the patient also had an injection into one of their joints for arthritis. And then when they rechecked it, it was okay. So it suggests that this mechanism for delivering steroids is still relatively safe. So there are newer mechanisms on the market now. This is an exhalation delivery system. So the idea here is that this piece goes into the mouth and this piece goes into the nose. And so as we breathe out, the soft palate closes. So so your breath carries the medication to the nose, but instead of turning down and going to the lungs in the normal pattern, it circulates back up higher into the nasal cavity. You get more nasal cavity distribution. Here's another way to depict that, where, if you use a standard spray, most of the distribution is to the front of the nose, where your sinuses are not. Well, if you use an exhalation system, you get it higher and more into the paranasal sinuses. So this is a newer medication. It's still, the medication is still the same. It's actually the same as Flonase, but it's a higher dose that gets distributed in a very significantly different way. And in that reason, it was able to get an FDA approval. And here are the studies that basically show its efficacy. Basically, again, this is where you want lower lines. And when you give the drug in a lower line, people's congestion got better, their drainage got better, their sense of smell got better. Okay. So this is randomized to placebo or to nothing. How about when you compare it to standard sprays? So in patients who kind of failed standard sprays, what you're able to actually see is that there is a difference, even though the medications between this and this are the same. They're both fluticasone. But what they're able to kind of show is that by delivering it in a different way, you actually get a symptomatic improvement in these patients. So I think this is a really nice study that shows it's not just the medications, but it's getting it to where it's at. And that's where surgery can help. That's where these sort of adjuncts can help. And just to show you what a huge impact on quality of life this measures, if you look at the improvement in people's quality of life, using by standard measures, this is published through the NIH, only getting a hip replacement or getting gastric bypass surgery was better than the higher level of exhance. I mean, I think that's pretty terrific when you see what improvements we can make in people's quality of life. Okay, so there are other things we can also do in the clinic afterwards. So this is that same drug-eluting stent, but now we can actually place it in the office to help control polyp recurrences. So unfortunately, polyps do come back. And so this is that same sort of deployment device that we can actually deploy into the paranasal sinuses. And then as it elutes over 90 days, it can deliver steroids topically to the area and help reduce the polyps. And this, in the right person, can be very, very effective, particularly in patients who are diabetic, where oral steroids or steroids through their blood system are contraindicated because it would drive their blood pressure crazy. This is how it looks sitting in, and then it gets removed 90 days later. It's a fairly big device, but most people tolerate it actually very, very well. And here is the phase 3 trial on it, where basically you had some people who had a fake implant versus those who had a drug-eluting implant. And it has a 60% reduction in the need for revision surgery. And I would say that that's been the same in my hands. So are there new and creative ways that we can deliver these kinds of medications or steroids? So this is the work of one of my collaborators in chemical engineering, Steve Little, and I. And some of this work is actually sponsored through the foundation, where we're able to actually now get these things called temps, which is basically something that's a gel when it's at room temperature or colder air. But when it touches the warmer nasal lining, it actually forms a gel. And we're able to get this microsphere gel to actually deliver steroids continuously over 1 month. And we've done this in rabbit models. And then we've now made it a freeze-dried thing that can be really easily reconstituted. And we're able to show that actually it doesn't impair the cilia or the nasal lining, that's able to work underneath it despite its deployment in this. And so this is some research that we're continuing to do. We're applying for another NIH grant with this, and much thanks to the foundation, because they were able to provide some of the funding to help us actually move some of this work along to the point where we're actually looking for NIH funding now. So the latest and greatest in our last couple minutes really has to do with biologic therapy. So this has taken over the world. You see a lot of commercials for cancer, but it also has some, well, you might have seen the commercials for the drugs I'm going to talk to you about as well. So dupilumab is the poster child for this. And this is a monoclonal antibody. So its antibody means it blocks a specific protein or cell receptor on the cell lining itself. And in this particular case, it blocks IL-4 and IL-13, which basically are those mediators of that type 2 inflammation I talked about, okay? And it's been shown against placebo to significantly improve the breathing in patients. It makes the polyps a bit smaller, helps people smell better, and reduces the need for vision surgery. And so this has been a huge adjunct in people who've really struggled with it, with this particular disease process. And in truth, you might have even seen their commercials on YouTube or the television itself. They're advertising it for atopic dermatitis, and it also is efficacious against some asthmas. And here's that trial that was done for this. And really what it, and some of this work was actually done at Pittsburgh by my former partner, Stella Lee. And what it does is you gave intranasal steroids like standard of care, and they're randomized to placebo versus this drug. And what it really showed was an improvement overall in congestion and polyps. So this was a really, really big deal. And this is how it got its FDA approval. And this is a patient, and I've shown you this slide a couple times, but this is the patient on Dupixent. So it's not like all the polyps necessarily go away, although some people it can, but it shows a really significant reduction by blocking those antibodies. So its disadvantages are that you have to self-inject every 2 weeks. It can have some side effects. It can demonstrate this granulomatosis with polyangiitis that is very uncommon. Its biggest problem is it costs a lot. It basically costs like a Honda Civic a year, or I guess college tuition is more than this now, but it's a fairly expensive drug. And unfortunately, it seems like for many people, the polyps recur when you stop. Now, there's some data that suggests that maybe that's not the case in everybody yet, but I would say that data is not quite mature enough for us to give recommendations. And so we really wanted to understand this using our cohort of patients here. And so what we really did is we compared Dupixent or dupilumab to endoscopic sinus surgery with saline irrigations and nasally delivered steroids. And the groups were actually very similar. The biggest difference was that the dupilumab group had one more surgery than the sinus group before we did their surgery again. And but interestingly, that the other big difference between them is that the patients who had surgery actually had a little bit worse CT scores than the other group. And this is what we found. I'm sorry, it's a little bit of a busy slide, but as expected, the sinus surgery did better at getting rid of polyps because you physically removed them. So that's not too terribly surprising. The sinus surgery didn't do quite as well when it came to the nasal drainage, and particularly didn't do as well as the sense of smell. So the sense of smell was really improved with the dupilumab versus the sinus surgery, but in almost overall, they're actually pretty similar. So it shows that Dupixent is not for everybody, and standard surgery and topical steroids actually are really, really effective without having that huge cost that, you know, can be quite a burden at times. Okay. And I would be remiss to not mention the other monoclonal antibody, which is mepolizumab. This blocks a similar type 2 inflammation. This is the randomized control trial for this. Again, placebo versus control, basically a fake drug versus real drug. And it shows, again, a significant reduction in the polyps, but the symptom scores were super great between the two, but it's probably a slightly underpowered study. Despite that, this has FDA approval, and it becomes an alternative when Dupixent's side effects take effect. It's also, its big benefit is in very specific subtypes of rhinosinusitis, like that GPA that we had mentioned earlier. So with that, I'm going to plug one last thing. If you're really interested in sinus, the American Rhinological Society has a patient-facing website called sinushealth.com. My team, Dr. Chobe and I, have both written some things for this. And it's really our desire to be to really put clear information in a centralized place for patients to be able to find that information. So I'd encourage you to look at that if you're really interested. And then, of course, I want to just thank my partners, Carl Steinerman, and our newest partner, Garrett Chobe, who trained here at Pittsburgh and then did his fellowship at Stanford, and then was at the Mayo Clinic for the last 5 years before we were able to successfully recruit him back to Pittsburgh. These fine individuals are also a key part of this team and do many of the same work with me. So with that, I'd be happy to take any questions. Thanks so much for your attention, and I really appreciate the opportunity to be here.
Dr. Wang, thank you so much. We have quite a few questions. If we don't get to your question today, we will get it answered for you via email. So let me start. Is post-nasal drip synonymous with chronic rhinosinusitis drainage? If not, please define what it is.
So post-nasal drip can sometimes be from the nose, but unfortunately that's relatively rare. Most of the time, if it's from the nose, you can see it with a nasal endoscopy. So you can see it at the time of, because it's actually kind of pouring out from the sinuses itself. So in the majority of time, though, with postnasal drainage, it's either primarily a throat inflammation issue, or it can be an allergic issue. Okay, so both avenues have to be sort of looked into. For the throat, what happens is, as we're swallowing the 1 to 2 liters of mucus we swallow every day, and your nose is making the right amount, it's happily making the amount it's supposed to, you feel it because the back of the throat's irritated. Right? If the back of the throat's too thick or too irritated, and sometimes we think of things like reflux as a common cause of that. So that postnasal drainage feels like, it's there all the time, but your nose is doing what it's supposed to do. We shouldn't change what your nose is doing. We really have to modulate if that throat can be adequately controlled. And there's some over-the-counter things that help, lifestyle modifications that help, and then once in a while, reflux medications are necessary to do so. But unfortunately, it's not synonymous with chronic rhinosinusitis. And in fact, most often isolated postnasal drainage is almost never from the sinuses, maybe less than 10% of the time.
Thank you.
Thank you for the question.
Yes. How much do obstructions from previous fractures to the nose impact the risk of infection?
So it depends a little bit of where the fractures are. Most of the time when we have nasal fractures, let me take off my glasses here, it's really actually to these nasal bones above here, and it actually doesn't really cause much change to your sinuses at all. Now, fractures to the nasal septum can cause it to be difficulty to breathe, have some difficulty breathing through the nose, but neither of them have ever been shown to cause an increased risk of infection. Now, if you have a really significant fracture where the sinus walls themselves are fractured, that can. Okay. But that's really pretty significant. That's not when a basketball sort of pumps you in the nose, or your child does a reverse headbutt to you, or the normal things that most of the time nasal fractures come from, or even fistfights. Most of the time, those are really significant things like motor vehicle accidents, ATV accidents, really significant falls. Those are the kind of things that usually contribute to it. But the structure of the nose itself, while it can really impact the way we breathe, don't really impact our risk of infection.
Okay.
Thank you for the question.
Are there any lifestyle changes someone can make, diet, exercise, environment, pets, that can help the symptoms of chronic rhinosinusitis?
So this is a tricky question to answer because so if you look at the data would suggest no. But I would tell you that I think that there are people who do certain elimination diets that really make a big difference. Okay. I would say the most common I notice is dairy. So there are some people, when they take dairy, they notice that they really have a lot of nasal congestion associated with it. And that is, even if you would say that the data doesn't support it, if you're one of those people who get a benefit from that elimination, I think there's some value there for sure. In that really specific group of aspirin-exacerbated respiratory disease, alcohol elimination actually also does help. And there's some pretty good data to support that. But the most common of which I usually tell people is if you look at dairy. But the
Mhm.
other lifestyle things are much, much more involved with allergies. They tend to be much more involved with allergic rhinitis.
Okay.
And the symptoms seem to overlap, so people sometimes feel better. But from the sinuses themselves, that we don't really have much other data. So
Okay.
it's a little bit of a tricky question to answer.
Um, Let me ask, we have time for two more.
Okay.
Is there any harm in using a saline sinus spray several times a day?
No, not really. I think that sometimes if you were to use too much of the rinses, the irrigation rinses,
Mhm.
and you're talking about a lot. You're talking about like 5 or 6 times a day. Sometimes that can actually act as a drying kind of problem. But
Okay.
in general, no, the sprays tend to be pretty safe, and you can use them 4 or 6 times a day without much issue.
Oh, wow. Okay. And then it's really just a final comment.
Mm.
This is an outstanding presentation. Thank you so much.
Thank you, Heather. I appreciate the time.
Yes, well, we have one of our guests put that on as in Q&A, but I think it's been wonderful, and I think this is a topic that every single person knows someone who has these types of issues.
Sure.
So
Sure.
thank you so much. And thank you to our audience today. We always love it when you join us. Take good care. Thank you, Dr. Wang.